as well in terms of what is the structure of the current evidence-based practice, so that we can see some common themes across. Then we will talk about, when we talk about diagnostics, treatments, prognosis, there are a lot of common themes across any medicine. I'm not necessarily going to use the term allopathic, Ayurvedic, Western medicine is medicine. Okay? If it works for patients, it works. And then, how do we claim, how do we know what we know? That is the bottom line, right? So we cannot have multiple definitions in terms of making claims. When I say something works or does not work, both ways, there is a process to it, and we will talk about that as well, and then I'll summarize and take any questions. So, I don't know if it's going to work or not, because there is a special software on my computer which is not correct, but we're not able to connect, so what we're going to do is just have verbal communication. Alright? So, let me just close this because that's what it was. Okay. Give me 1 second. Let's skip this. Go straight here. So here, basically those were 2 slides to ask. When we say medicine, what comes to your mind? When we say the word or the term evidence-based medicine, what comes to your mind? So when I teach students, whenever I ask them about evidence-based medicine specifically, they tell me research, and I ask, what is research? Sometimes they say statistics. I said, okay, how does that relate to? So what the point here is that a lot of terms get used interchangeably, and we don't nail it down to specifics what exactly it means. So that is the main thing. But here is a simple definition of medicine and evidence-based medicine. So at the end of the day, this is a science. So we'll talk about what do we mean by when we say science, or belief, or opinion. So there is a hierarchy there. But bottom line is this, what ultimately patients care about. No matter what you give them, how you treat them, they care about, do I feel better, based on whatever is bothering me, troubling me. At the end of the day, that's what they care about. And second point, when we talk about feeling better, we have to talk about balancing the benefit and risk. There is no such thing as 100% safe or 100% bad. There is a profile benefit risk. If anyone can make a claim that somebody has a diarrhea, let's say, how bad it is, and if we say, eat more cucumbers, okay, let's say simple as that, right? It could be. The question is it going to first stop the diarrhea, and hopefully I will not have a very bad episode of respiratory distress due to eating my cucumber. So you see how we talk about benefit risk profile. So those are the 2 things that patients ultimately care about. So it doesn't matter where the medication is coming from, where the intervention is coming from. And then when we talk about evidence-based medicine or any evidence or science, at the end of the day, bottom line is, how do we know? It's not about I or you only. How do we know what we know? How do we make claims? I can make a claim, I can make a hypothesis, but can I explain to somebody else or not? And that's what distinguishes science and belief. So when we talk about science, there are some misconceptions there. That science is just facts. Is it? The question is not that. It's the process to achieve the goal. It's not the goal. But how do we get to that place? Right? I can stumble upon and reach clear water. But if I don't know what clear water looks like, I might just pass by, I don't even know that I was in clear water. But if I describe that here is the pathway, you take bus, transport, whatever, take the road this and reach there, and how it looks like, I can actually say that, okay, I reached or did not reach. So science is not just facts, but it's a process. People say theories are guesses. It is not guess, actually. Within the guess, there is a gradation. Informed guess versus a wild guess, right? So there is in the detail. The theories, actually are there, which we also call biological plausibility. So we say, okay, this is how it works, and then we quantify whether it worked or not. So it's not about proving, but it's about proving whether it works, and disproving also if it does not work. So it goes both ways. It's not simply one way that I am using a scientific approach to prove something. Because you can design the experiment, but what happens, result, you can't control it. And you should not control it, because that we call fudging. Alright, so results happens. Alright? But one of the biggest tenets of science is reproducibility. If I or you or anybody in the world does that experiment, either here or somewhere else, we will not get the same result, but we should get similar result. Definition is that it should be reproducible. If it's not reproducible, then it cannot be considered scientific practice. That's the essential tenet, basic fundamentals. And the second level of the basic tenet of science is, if we can explain why something happened, it's not about, okay, patient got cured, let's be happy, proud, and move on. But we go further from there and try to explain how that works. That's called biological plausibility. Right? You have a theory also to explain how it works. Here is an example. Okay? Either AF, atrial fibrillation and hypertension. Lot of studies, big studies, large studies have been done that people, let's say, who have AFib or who have high blood pressure are more likely to have AFib and can have bidirectional also, both ways, right? And it shows that they are 1.5 to 2 times more likely to develop, AF, with high hypertension compared to people who do not have it, right? But then, the association is consistent, so that's the quantified results. But you have to look also at how it happens, which I'm explaining here, that what is the physiological mechanism behind that what we see and how we see it, right? Ideally, for the perfect evidence or very good evidence, we should have both. But if we have to decide, do I care about biological explanation or theory versus quantified outcome or the results? People would go anywhere, any day over epidemiological plausibility. I don't care how it happened, but it happened. All right, I can see the results in most patients, average patients, right? This is working. So here is an example, right? We thought first, right, moderate alcohol intake is good for you. But as the more evidence started coming, right, people had very good theoretical explanation of how it might work, which I'm providing here. But now, a lot of trials came and shows alcohol has zero benefit. Actually, it's more harm or less harm. So alcohol consumption, if you look at the latest evidence, is not associated with any improvement in health outcomes. So that's where you see there are a lot of biological plausibility, but when you look at the epidemiological explanation or results, it shows no, it's not effective. So that's the choice, we have the two choices, okay? So, belief when it comes to, by definition is belief, I can believe that it's nighttime right now, although it's daytime, I see the sun there. So it doesn't require any logic and reasoning. So that's why we don't go for that. It lacks any plausibility, as well as epidemiological or biological, either of those, as well as there is no reproducibility. I can dream about something, but I cannot teach anybody how to dream the same dream again. I cannot, right? So that's why it's not there. So, getting back to the question of how do we know what we know? So there is a process there, all right? So in medicine, I'm trying to oversimplify, but broadly I'm talking about clinical medicine. We have come up with one good metric from the evidence-based movement is we classify the questions into domains, right? So we say domain is diagnostic accuracy, and you see it follows a chronological order in terms of what happened first, what happens second, what happens third, fourth, fifth, and sixth. So we start with diagnostic accuracy, and again, physicians evaluating somebody is also a diagnostic test. When you do a physical exam, when you do assessment, differential, that's also a diagnostic test, all right? Then we move to diagnostic utility, then we move to prognosis, treatment, interventions, and finally harms also, what are the side effects of something. And what the field came up with, that not every single study designed from epidemiology can answer every single question in medicine, depending on the question domain. So for example, when we are talking about diagnostic accuracy, the best study design, and by best I mean the most unbiased, right, is a cross-sectional analytic study design, and so on and so forth, except harms. For harms, there is no gold standard study design. Anytime the signal can come from anywhere and you have to pay attention, you cannot ignore any side effects. So that's why there is no standard, all right? But for all other questions, there is a hierarchy there, and approval of drugs, devices follow this principle as well, all right? And that's why, again, very important question that you have to match the study design to the research question. And there is empirical evidence, history of medicine shows, you see so many interventions here which were found in large observational studies to be effective when it came to testing in randomized controlled trials, they fell apart. People made careers recommending stem cell transplant for breast cancer. And the first study came, it was an observational study from Medicare database, right? They took 100,000 people and analyzed it, and emotional appeal was made to the Congress. FDA approved it reluctantly, and there were departments and multi-cancer centers here using stem cell transplant, okay? And later on, when the randomized trial came, first from South Africa, it was found no efficacy. Second trial came, no efficacy, and they had to reverse, okay? So I'm showing you many examples there, which was found, the interventions which were found to be effective in observation studies flipped completely, okay? So that's why you have this evidence pyramid, right? That what is considered expert opinion is the lowest in the hierarchy of evidence. And when you do a synthesis of similar studies, that's considered the highest level of evidence that you can produce for, depends again, intervention, prognosis, accuracy, etc., etc. But here is a word of caution. This problem of misclassification is prevalent everywhere. Just because something is called a randomized trial, it does not automatically mean it is well done. Because there is methodology or methodological details at every step where you can mess it up. Okay? And we can debate whole day what we call mess. Actually, the technical term is high risk of bias, low risk of bias. Okay, that's the technical jargon there. Okay, so conduct is very important. And again, there are examples. These are all RCTs only, randomized controlled trials. Small trials, badly done, a lot of issues. They found things that are effective. And finally, when people did large, well-designed studies, turned out that it was not effective. The results flipped. Within randomized trial, I'm showing you this variation. Okay, that is there. So basically, the question, what I'm asking is reversal of something that we know is a bad thing? The answer is no. It is not a bad thing. Because research or discoveries, they're always a cycle. It's not that today I accomplished something, oh my God, I'm the best, and go cheering up. No. We can always make something better. Or find out that what we thought was better turned out to be not good. Okay? So that's why this cycle continues. You must have heard PDSA cycles, plan, do, study, act. Again, evaluate, again. So circle never stops, right? It keeps on going. You start with, let's say, lab studies, mice studies, translate the research. There's safety, phase 1, then you go into some efficacy, and so on and so forth. Then you go to phase 4, pragmatic trials, real world. Right? You find something, you discard, you tweak, you improve, and so on and so forth. Cycle keeps on going. It's a loop. And that loop is very important. But the biggest contribution of science to medicine, or any field for that matter, has been standardization. And I think one of the speakers talked about standardization. Why it is important? If you don't standardize something, I cannot even talk to you and explain to you what I mean. Because I say, how are you? It sounds like a very simple question. But if you like to go into details, we don't standardize that. Are you asking me how my life is? Are you asking me how I'm feeling now? How I felt yesterday? We don't know, right? Until we clarify. Same thing is about standardization. Words have meanings, right? And why do we need standardization? Here is the basic principle of current medicine. Here is the hypothesis. Similar patients, how we group similar is a $1 million question. With similar interventions will produce similar effects. In most patients, nobody says 100%. But what is similar varies, but that is the key hypothesis, right? Why do we need standardization? Most important, safety, right? Because if we are not using in a similar fashion, somebody mentioned, turmeric, let's say, right? Okay, in certain doses, it might be effective. I don't know the efficacy of it. We can talk about, but in higher doses, we know that it is associated with hepatic toxicity. It can kill you, right? So that's why safety is important. If you don't define it, for example, the definitions, you cannot measure the quality of care without definitions. You cannot think about efficiency. You cannot think about equity. Okay? You cannot reproduce, which is very important to standardize things. If I don't standardize reproducibility, I cannot teach you. If I touch somebody and the fever is gone, but if we don't know the threshold of fever, what is considered fever, we take it for granted. You'll be surprised, we were trying to do a clinical practice guideline. The panel debated for 10 hours that what should be the threshold. Especially in febrile neutropenia patients undergoing cancer chemotherapy, and thrombocytopenia happened, they debated that. And finally they came with recommendations. A lot of things look very simple, but if you get into the detail, there are a lot of things, because if we don't define those, how can I teach others? I made a very good bread, but if I don't give you the recipe, that dies with me. You cannot teach future students how to make that same bread again and again and again. And same applies to the drugs, same applies to the treating people how to diagnose. All right? And here are some list of the products that came as a result of that same standardization. If you don't standardize, you cannot come up with protocols. You cannot come up with clinical practice guidelines. You cannot have clinical pathways how do we treat people, because then only the knowledge can spread if you create these protocols, right? And again, in research also, the same thing came out, how to report, how to conduct something, right? That's where, even now they have a consort for Ayurveda, by the way, for standardized reporting of randomized controlled trial, right? And same thing goes to the healthcare systems, where unless you standardize, you cannot create those systems. Now, main reason for standardization is, again, if you don't have explicit rule, you cannot prescribe. I enjoy massage. I'm pretty sure everybody in the room enjoys massage. Okay, it feels good. But how do you prescribe? How many times? How long? What kind? So if you don't standardize, if you cannot standardize, we cannot be prescriptive about it. You cannot make the rules as you go along. So that's where standardization helps to be prescriptive about anything. So let's talk about a little bit diagnostics, which is very common for any forms of medicine. First, you say what is the problem. That's what diagnosis is all about, right? You can use whatever word you like. All right. So let's look at, because if you don't reach a diagnostic threshold, you cannot start the treatment. Because what are you treating if you don't know what is the problem, right? So we agree on that. So again, without going into detail, the hierarchy of diagnostics is you start with known cases if you want to develop something in diagnostics, right? Take known people with disease, healthy people, then you move to suspected, right? But bare minimum is, if it's a scientific enterprise to diagnose, that if Dr. Bapat sees a patient, right, says patient is XYZ, if I see that patient, hopefully I will say the same XYZ and not ABC. We'll come to the next problem later. So, studies have been done for reproducibility. Let's look at this, right? That, if you don't have standardization, you don't know what patient population we are talking about, right? So, unclear target population, right? And again, so many examples here that if you don't have a clear distinction of diagnosis, how are we going to move to the next step of discovering new therapies, right? Whatever process might be, right? So what I'm saying is the art needs to be quantified. Even if it's art, if I touch somebody and treat somebody, if I don't articulate that verbally or in writing, what exactly did I do? What exactly did I evaluate? How can I teach somebody else how to do the same thing again and again and again? So that's the challenge. So if we cannot diagnose appropriately, we will miss on so many things, all the way from learning mechanism of action to all the way to how do we get approvals to implement at a mass scale. Regulation, how do we satisfy the needs of regulation? That is the most important aspect associated with diagnosis, and if you don't standardize that. Right? So bottom line, without diagnosis, treatment is anecdotal at best, because you cannot reproduce it again and again with other patients. And if we work on diagnosis, right, treatment becomes scientific, reproducible. That's what we mean, right? So those are the examples even from Western medicine or modern medicine, that when people did not know how to classify as simple as the chronic fatigue, they call it now, fibromyalgia, right? People did not know how to address it. What do we do with it? Depression research, if you look at pre-DSM, it was all over the place. Now, after DSM, people finally started standardizing, looking at drugs, etc., etc. And here is the list of studies that I found, evaluated myself, in terms of looking at various diagnostic domains in Ayurvedic medicine. Okay? And if you look at exception, right, some are there, but I'm not talking about known and unknown cases, suspected, sensitivity, specificity, all those stuff. I'm talking about simple as that, agreement between the two evaluators. If we agree that they have the same thing, is at best like 0.6, which is not good at all. It's not considered very good agreement. So we need to articulate that secret into writing, I guess, so that we can move forward. So that is the nutshell in this case. The key limitations, very important concept. We are talking about the bare minimum agreement. We two can agree, but did we agree on the right thing? We can agree or disagree, but we don't know who is right here. So for that, you need a reference standard. That what is the truth at the end of the day. So the two problems are there, right? Even with agreement, you cannot determine the accuracy in absence of a reference standard. Again, I'm not getting into the quality. All these studies are very high risk of bias and mostly done in healthy participants, not even sick participants. Okay, so that is one of the limitations. So bottom line, implications for research and practice is low interreliability, weakens the validity, because that's the bare minimum standard, we have to achieve to recommend, to teach, to practice, etc., etc. And if the diagnostic, which is the first step of moving anywhere, right, for any intervention to develop, if we cannot achieve that accuracy, where are we going next? We are going to bring it further down, the risk of bias in those. And that's why I think we need to invest in the standardization of diagnostic tests, tools, training, before we move any further. Because again, if you're taking from one method something and mixing it with other, right, but let's do a priori, so that whatever we observe, at least we can be sure about the reliability of those findings. Here is the prevalence of low quality evidence is not only limited to one form of medicine or the other. Here are some more examples where you see vitamin C, these hypotheses which we have proven wrong as the field improved. Why I'm showing you that the problem with bad science is not only to, attached to one kind of medication or intervention or form of medicine or practice. It's prevalent everywhere. And all the fields first have to acknowledge every field and then try to improve. Here is some examples. Somebody talked about hydration also. Of course, it's one of the top 10 myths how much water we have to drink. There is no standard for that. You drink when you feel thirsty. Okay, that is the main thing. So there are some examples as well, in daily lives. All right. So here are the current gaps and some recommendation how to move forward. So if you talk about diagnosis, the going forward is, let's work on developing validated, standardized diagnostic tools with tested at least reliability, and then we'll get into accuracy as well. If we're going to talk about interventions, okay, randomized trials could be done, but I think some basic research will also help in understanding the mechanism, documenting, assessing safety, then benefits. Just because something is natural, and if we don't know, we cannot assume that it will be safe either. Let's work on terminology and constructs, what exactly they mean, further refine, maybe simplify the language so that more people can participate and understand. Outcome measurement is a big problem because most of the outcomes in absence of markers will be subjective assessment. So at least test it out in terms of blinded assessments to see how reliable they are. Okay, but that will happen after we have worked on all this. And very important, publication bias is a major problem in all forms of medicine. When study results are positive, they publish it, negative, it gets swept under the carpet. So I think register those trials a priori so that people can track the outcomes to reduce their publication bias and not publish only negative results. So some more hypothesis testing is not a Western or Eastern or whatever. It's a global phenomenon. Science is science. It does not belong to one individual or a country or a domain. I think those are processes through which we can achieve outcomes. And bottom line is, I mean, so Ayurveda has very rich conceptual framework. I think it needs to demonstrate, the next step will be to demonstrate those conceptual framework into practical applications. Whether it's diagnostic, whether it's treatment, prevention, whatever that domain might be. And these are the benefits if we improve the methodological rigor of whatever we are talking about in Ayurveda or any medicine actually. Okay, to enhance the scientific validity, and that will help, I think, integration into routine practice. If you test systematically, you can innovate then. Because if you cannot quantify the current status, how are you going to innovate? Right? So, and again, the more specific we make it, we can train people, educate people. It cannot be magic. It has to be a thing that we can teach people so that we can reproduce. That's why I think standardization. I cannot repeat more. So that I think is the last one. In conclusion, any scientific enterprise requires systematic approach to assess whatever you're assessing, and there is a process. And within that process, you can do a good job, which is called methodological rigor. You can do a poor job. Simply terminology does not mean anything on its own. You can do a good job or a bad job. And path forward, I think, isn't rejection. It's more about translating into reproducible outcomes. So that's how I see it. Full disclaimer, I have no idea how Ayurvedic medicine works. I don't know the theories behind it, but one thing I realized reading the literature, that once you read the scientific process, you can make a claim whether it is a reproducible approach, systematic versus organic approach. Organic approach is called preferences, systematic approach, reproducible approach gets classified as science. So that's one thing common. No matter whom we talk, the language remains the same. We call it science. So that's in a nutshell. Thank you.